Could I ask Gerard and Kenneth to put themselves on, take themselves off mute and put their videos on, please? Welcome everyone to Sight for All's COVID-19 webinar. My name's Judy Hatswell, I'm the Executive Officer of Sight for All. We're very grateful to have you all joining us today. Just a reminder, I know I've said it a couple of times, if you can turn your videos off and put yourselves on mute, then it helps us with the internet speed and also with the background noise. Before I hand over to our presenters, I just wanted to let you know that we're recording the video, the webinar today. The video will actually, or the webinar will be available on Sight for All's new COVID-19 website that is going to be launched tomorrow. So we just have another couple of people joining. So I'm just going to invite them to come in. And welcome to the new people that have joined us. Today's presentation has a question and answer session as part of it, and I would encourage you to utilise this opportunity to ask questions of our two expert presenters. We have a specific question and answer session, but you can put your questions in the chat function throughout the presentation, and the presenters will address those at the appropriate time. So we have another couple of people joining, and then I'm going to hand over to Professor Gerard Sutton. Professor Sutton is one of Australia's leading ophthalmic surgeons based in Sydney, Australia. He's internationally recognised as an expert in cataract surgery, laser vision correction and corneal transplants. Prof Sutton is head of the Corneal Unit at the Sydney Eye Hospital and visiting Professor of Medicine in Mandalay in Myanmar. In addition, Sight for All is delighted to have Professor Sutton as our lead visionary for cornea. Would you welcome Prof Sutton? I'll hand over to you.
Judy, thank you very much, and thank you for all the work that you've put in to getting this webinar together. And I think it speaks volumes for you and also for Sight for All that there have been so many people who have signed up for this. And I think it's also a reflection of how important the topic is and how necessary it is. And really my other important job here is just to welcome Dr Kenneth Li, who is a friend and colleague from Hong Kong with a significant experience in this area, and it was his publication in Grafey's Archives on this particular topic which has really established him at the forefront in terms of assessing the risk, dealing with the risk, and giving advice about how to deal with the COVID-19. Kenneth is the Chief of Service at the Department of Ophthalmology at the United Christian Hospital in Hong Kong. He's completed VR fellowships at the Royal Liverpool University Hospital in Liverpool, and he's won numerous awards, including the Distinguished Services Award at the APAO in 2018. So he's our expert, and I'd like to invite Kenneth to give his presentation. Thank you very much, Kenneth.
Thank you for the very nice introduction, Gerard, and I must thank both Gerard and Judy for organizing this wonderful webinar, and which is involving so many countries and different time zones. Is a very difficult task. So I'm going to start my presentation. Okay. First of all, a big hello from Hong Kong to everyone in Australia, Bhutan, Bangladesh, Cambodia, Ethiopia, India, Laos, Mongolia, Myanmar, Sri Lanka, and Vietnam. I work for the Hospital Authority in Hong Kong, which is the public health service provider, equivalent to the National Health Service in the UK. Our team provides ophthalmic service to the Eastern Peninsula of Kowloon with a population of around 1.1 million. Before I start, I would like to thank all my team members of the Department of Ophthalmology, Pathology and Infection Control. They have been working very hard over the past few months to implement infection control measures to minimize transmission of COVID-19 to both patients and staff. This is the outline of my presentation. So I'll talk a bit on the background and then on the stepping up of infection control measures. And we'll have some time for questions and answers. Hong Kong experienced SARS back in 2003, and at that time I was just an ophthalmic trainee. We know COVID-19 shares some similarity with SARS, yet there are still many things unclear about this new virus. What we are doing now are based on a combination of our previous experiences in SARS and our current knowledge of the SARS-CoV-2. This is the world map of confirmed cases as of yesterday. As you can see, United States, Spain, Italy, United Kingdom, and Germany have the majority of confirmed cases. It was estimated by the WHO the global mortality rate was around 6.9%, although this is likely to be an overestimation because we know there are a lot of cases which have not been tested positive. On the rim side, according to Reuters, there are more than 90,000 healthcare workers globally who have been infected with COVID-19, and at least 260 nurses and probably similar numbers of doctors have died as of this month. So let's look at the situation back home and around Asia. So Australia, India, and Bangladesh appears to have the majority of cases in Southeast Asia. And Hong Kong has around 1,000 cases so far. And this is followed by Sri Lanka, Vietnam, Ethiopia, and also the other countries. This is a graph which I took from the WHO website, showing the distribution of cases among the different continents. As you can see, at the moment, Europe and America have the majority of cases. I'm particularly worried about the blue color here, which is the number of cases in Southeast Asia. As you can see, is slowly creeping up. And it's because of this I asked Gerard for his kind help to organize this webinar to try to alert my fellow ophthalmologists in Southeast Asia. The global number of confirmed cases have exceeded 3.5 million as of today, with over 260,000 deaths so far. On the bright side, the majority of cases are mild. SARS in 2003 put Hong Kong in a pretty unique situation. Out of the 8,400 cases in the world, Hong Kong had 1,755, of which we had a total of 298 deaths, including 9 healthcare workers. So this has really left an indelible scar on the entire city. And ever since 2003, I think people here have always had a very low threshold for wearing masks. We are very worried of elevators so that we have almost 2-hourly cleaning of all the buttons. And hand sanitizers are ubiquitous in all hospitals. Temperature checks and at all major buildings as well. And this is the sort of baseline we had in Hong Kong. At present, there are 1,041 confirmed cases with 4 deaths in Hong Kong. The first case was confirmed in late January. And the number of, and then we had mainly imported cases initially, followed by local cases with clusters involving religious gatherings and family gatherings. And more recently, we had a second wave of imported cases from residents returning from America and Europe. And we have been quite fortunate as of today. We have no local infected cases in the past 17 days. So if you go to the streets of Hong Kong, you can see almost everyone is wearing a mask. So as soon as we had the first case, we heard of the first cases in the mainland China, the government actually issued an alert in late December. And all the medical community was already on alert. We have listed COVID-19 as a reportable disease, a notifiable disease, and hospital visits were limited. Everyone coming into the hospital will need to wear masks, including relatives and visiting patients. And we established a quarantine center in Hong Kong, and we cancel even the Chinese New Year fireworks, which is the biggest celebration in our calendar year. We declared the first confirmed emergency status in late January. And by the time we had 8 cases, all the schools are closed. And everybody coming in the hospital, we need to have the temperature checked, and people are at a very low threshold. So we use tissue papers to press buttons on elevators. And every time when they come home, they immediately sterilize their hands, take off their clothes and disinfect them, or at least air them. And all their shoes and surfaces are cleaned with bleach. This is common knowledge for the whole entire population. So next I'll talk about the clinical features of COVID-19. So we know that from early publications that the most patients involved are those of 60 years old or above. And this slide summarizes the clinical features of COVID-19. Mainly they have fever, fatigue, respiratory tract infection symptoms, mainly dry cough is the most common symptom so far. Patients with pre-existing illnesses such as cardiovascular diseases, diabetes, chronic respiratory diseases, and hypertension are at higher risk of developing severe complications from COVID-19. It was thought the incubation period is around 2 to 14 days, with possible outliers up to 27 days. This 14-day incubation period is very important and lay down the foundation of our epidemiological history screening for travel, contact, and clusterings, using 14 days as a cutoff, as well as the 14 days quarantine policy in Hong Kong. Evidence have demonstrated the transmission is mainly by droplets and contact, including contact with contaminated surfaces of equipment. However, it does not support routine airborne transmission. Airborne transmission does not occur under normal circumstances. It has been except during aerosol generating procedures, such as intubation. So the WHO has recommended airborne precautions for these aerosol generating procedures. The virus is sensitive to ultraviolet light, heat, and 75% ethanol. The virus can live for hours on shiny surfaces and up to 5 days under certain conditions. So the next I'll talk about the implications for ophthalmologists. According to this study from China, with over 1,000 COVID-19 cases, conjunctival congestion appears in about 1% of cases. Another study involving 534 cases in China suggested dry eyes, blurred vision, foreign body sensation are ranked the top 3 related ocular symptoms. Some may propose that conjunctivitis may be the first symptom of COVID-19. As one of the Chinese experts, Dr. Wang Guifu, who visited a hospital in the Wuhan province back in late January, and he was wearing an N95 respirator at the time, but without eye protection. He later developed conjunctivitis and then respiratory symptoms, and was later confirmed to have COVID-19. So in terms of ocular manifestations, our knowledge is still very limited. According to a number of studies, conjunctivitis can appear in around 1 to 5% of cases. According to 2 anecdotal reports of ocular examination, they usually present as follicular conjunctivitis. This is taken from the Canadian Journal of one of their cases. So usually they present with follicular conjunctivitis, lid edema, generalized injection, and in this particular case, there is corneal involvement with pseudodendrites initially, and then more generalized involvement, so in the form of a keratoconjunctivitis. In another case report from Shenzhen in China, this patient developed conjunctivitis not as a presenting symptoms, but on day 8 after admission, raising the possibility that conjunctivitis can develop as a secondary infection rather as a primary presentation. There are other reports suggesting that COVID-19 may actually cause Miller-Fisher syndrome or Guillain-Barré syndrome. The possibility is either a neuropathic effect or maybe a aberrant immune response. So we are still, our understanding of the ocular involvement of COVID-19 is still very superficial. However, transmission of COVID-19 through tears secretion has been controversial. This publication in the Journal of Medical Virology showed that 1 out of 30 COVID cases was tested positive for the virus in tears and conjunctival secretions. However, other studies did not show similar results. At the moment, only 3 studies detected SARS-CoV-2 in conjunctivitis cases, whereas 2 other studies, including one from using Schirmer's test to look for tears carriage, was found to be negative. According to unpublished data from my own center, out of 53 confirmed cases in Hong Kong, we could not detect SARS-CoV-2 in conjunctival swabs. But the problem is our daily examination put us at a particular risk of contracting COVID-19 because of the proximity during the examination of our patients. So next I will talk about the infection control measures in an eye clinic setting. Before we implemented all the infection control measures, we worked very closely with all stakeholders. It was based on a three-level hierarchy approach, namely the administrative control, environmental control, and the use of personal protective equipment. As your clinical settings may be different from ours, I suggest you work closely with your local infection control experts before you decide on which type of measures to implement. I do not intend to cover everything in our paper. Please refer to this link, which you can get free access to the paper. Administrative control is the most important as it involves the largest number of people. It aims to reduce the risk of exposure of uninfected people to infected cases, and I will go through them, each of these. First is the reducing the attendances. We have a total attendance of around 500 cases a day in our 2 hospitals in Hong Kong. To lower attendances, we have been sending out text messages to patients' mobile phone 1 week before their appointments. In the message, we specifically ask for flu, fever symptoms, and those with recent travel. And also we offer free drug refill. Responding cases will have their records screened by our doctors, who will decide whether to accept the rescheduling or not, and also the timing of the rescheduled appointment. So out of the 10,000 messages we sent out between February and March, we had a response rate of about 12%. And this has caused a reduction in the total number of attendance of about 20-something%. Patient satisfaction is excellent, and the main reason for rescheduling is, of course, the patient's fear of COVID infection. Next is the patient triage. Every patient who comes to our hospital are screened by this questionnaire. So we know up to 98% of infected cases present with fever. So it's very important that we ask about fever and respiratory symptoms. Family members or close contacts with similar symptoms. Travel to outbreak areas. Occupation in terms of healthcare workers or those who work in wet market. And any history of contact with patients with COVID-19 in the past 14 days. Any positive response will mean postponing their appointment for at least 14 days, which is the current understanding of the incubation period. When we first started this, we also asked about conjunctivitis. In the beginning, when we asked about travel history, it's actually one of the most important history that you must elicit. It was difficult to get a genuine response from certain patients. So the IT department of the hospital authority and the immigration department have successfully linked up their systems for the past 2 months. So this is a great initiative. So we can look on the computer of our hospital whether patients had recent traveling out of Hong Kong. So we can obtain very accurate history of patients attending our clinics. This is the workflow of our triage system. At the entrance of our clinic, all patients have their temperature checked by the triage nurses. If positive, they will be asked to attend the casualty department for management. Then we screen for FTOCC. If positive and their eye condition is urgent, they will wait in a separate waiting area and have their visual acuity and examination done in a designated room. If the condition is not urgent or FT-OCC screening is negative, they will be offered drug review and rescheduling. And if they refuse, cases will be seen under standard precautions. So in the past 2 months, our hospital has installed these infrared cameras at the hospital entrances to look for any patients who have fever. But the downside is you need 2 people to man the station, one looking at the screen and the other healthcare worker will need, she's actually carrying a microphone and with a set of speakers there and stopping anyone who lights up on the screen. It's actually more labor intensive than doing it with the manual thermometer. And this is one of the initiatives from one of our local universities. So instead of looking at 2 different screens and try to identify who lights up on the screen, they have combined the 2 screens into one, and whoever has the fever will be automatically highlighted on the monitor. They call this a smart fever screening system. So the next is the suspension of elective surgeries and services. So to all elective procedures, including cataract surgeries, pterygium surgeries, have been suspended, and only emergency surgeries are maintained. To reduce the risk of transmission by aerosol generating procedures, we have suspended all nasal endoscopy or DCR. As non-contact tonometry can generate microaerosol, its use has been suspended, and in fact, intraocular pressure measurement should be minimized. As coronavirus may be present in the tears of infected case, the use of disposable tips and prisms is highly suggested. This can reduce the risk of transmission during the disinfection period. Ignorance can be dangerous, therefore providing update of knowledge of COVID-19 to our healthcare workers is crucial. It can help to protect both ourselves and patients. To reduce infection risks between healthcare workers, all staff members are required to report their daily body temperature before work and any recent foreign travel. Social distancing is strongly encouraged. For environmental control, protective shields are installed on all slit lamps. Similar shields can also be installed on portable slit lamps, shown here, and also OCT and fundus cameras. Regular disinfection is important. We have recently published some tips on preparing the protective shields in gravies, so it's freely accessible as well. If you need further information, you can let me know. I would like to acknowledge my friend Dr. Siddharth of the University of Hong Kong for providing this slide. I think some of you asked questions about how to kill coronavirus. It summarizes the suitable methods for disinfection for skin and also surfaces. As we know, coronavirus is covered by a lipid layer of envelope. Fortunately, this envelope can be disrupted, rendering the virus non-infectious. As I've mentioned before, coronavirus can survive on surfaces up to days. Disinfection is of paramount importance. Disinfection of ophthalmic equipment, keyboards, doorknobs, and particular mobile devices should be conducted regularly. Bagging of equipment that are difficult to disinfect, like keyboards, are suggested. Our hospital has recently installed a UV ultraviolet disinfection machine in our canteen to allow our colleagues to disinfect small items such as mobile phones and staff cards. It takes about 30 seconds to disinfect, and it's very helpful. But having said that, there is a lot of portable ultraviolet devices available on the internet. And recently, our hospital and also colleagues in Hong Kong have seen a few cases of keratitis related to the improper use of ultraviolet light, and that is something you perhaps need to look out for. This is a UV disinfection machine which our hospital has recently acquired. It can help to disinfect large areas quite quickly and easily. For both staff pantry and canteens, acrylic partitions have been installed to prevent droplet transmission. And more importantly, our nurses have put up these emojis on the partition to remind colleagues to minimize chatting during meals. To observe social distancing, all situation update meetings, academic meetings have been conducted using video conferencing on personal mobile devices. During this difficult time, I would like to stress the mental wellness of our colleagues should not be overlooked. For example, our team invited the hospital priest to lead prayers and do sharing before we start our weekly meetings. This is one of our weekly meetings. For the use of personal protective equipment, please refer to your local infection control guideline. For general outpatient clinic standard precautions, which involve the use of eye protection and surgical masks, are adequate. Okay, there's no need to wear gowns. When handling high-risk cases or confirmed cases, one should use goggles, N95 respirators, isolation gowns, and disposable gloves. And do remember to dispose gloves for each case, followed by hand hygiene. As I've mentioned, we practice universal masking in Hong Kong, and not only in hospital. Okay. We believe this practice explains for the relatively low prevalence in Asian countries, including Hong Kong, Singapore, Taiwan. It is a controversial topic, but I think even the CDC and the WHO are changing their recommendation. So on average, if you wear masks, there is a 6-fold reduction in the exposure to aerosolized virus. Remember the 7 steps of hand hygiene, either with the use of normal hand washing with soap or alcohol hand rub, before and after each patient encounter. In conclusion, COVID-19 is transmitted via droplets, contact, and fomites. It is important to remember conjunctivitis can be the first presenting symptom. The use of the 3-level hierarchy approach can provide a good framework for infection control. As there is variation of clinical settings, I encourage you to consult your local infection control experts before you implement infection control measures. I'm leaving you my contact and my Twitter account. Feel free to contact me if you have any questions. As individuals, we may feel discouraged in this uphill battle against COVID-19, but on the positive side, as global ophthalmologists, I don't think we have been so connected and working so closely together with each other for the same cause. 6 months ago, I could never have imagined I would be working with you all. I'm optimistic that if everyone takes a small step and keeps love in our heart, we will prevail. Thank you once again.
Kenneth, thank you so much for just such a comprehensive review of pretty much all the information that I think that everybody who is facing this pandemic required. So it's an incredible gift that you're giving to the rest of us, and we really appreciate your expertise. And it's really quite remarkable that Hong Kong has done so well, given its close proximity to mainland China, where of course it all began. And as you were speaking, I was just thinking about the ophthalmologist in Wuhan, who Li Wenliang, who first raised the issue of COVID with the authorities. So I think that, I think it is appropriate to remember him, and the fact that ophthalmologists have really got a significant role to play here. Judy, did you want to call for general questions now, and how did you want to do that?
Thank you, Gerard, and thank you very much for the presentation. It was fantastic. Lots of positive suggestions and practical suggestions for people to follow, so thank you. We are asking for people to put their questions into the chat box, which is right in the middle of the screen at the bottom, called chat. There were a couple of questions that were asked via the registration process. I believe some of these have been addressed, but questions around is COVID-19 transmitted by tear and eye discharge? And COVID-19 and eye implications through COVID-19. I don't know if there was anything more to say on those questions.
Kenneth, I think, covered that pretty well. The answer is yes. You can get the virus, or most likely you can get the virus in the conjunctival tears, but it's not a high risk. I guess the real point there, Judy, is that, and Kenneth touched on it, is what else should we be doing when we're seeing these patients? We're taking universal precautions, we're trying not to touch them. Kenneth showed a beautiful picture of the screen that you can have, which we use as well, on the slit lamp to prevent any sort of droplet spray. But apart from that, Kenneth, is there any other tips that you have in terms of preventing that contamination and infection when you are examining these patients?
Yes, we, at the moment in our hospital, every patient that comes into the eye consultation room, we ask them whether they have any allergy to alcohol. If not, then they will be offer alcohol sanitizers. In fact, I think I couldn't remember whether I mentioned that, is in the anyone visiting the hospital must wear a mask. So that, I think that is also a very important measure. So the universal use of masks in a clinical setting, including both patients and healthcare workers, and the more generalized use of alcohol sanitizers for patients. These are very important. Disinfection of the ophthalmic equipment after each patient encounter is also highly suggested.
Kenneth, I noticed one of the great pieces of advice you provided was that each country should work with their own infection control departments, because every country is different. So I think that's a good advice for everyone to take away as well. Another question was regarding the living period of COVID-19 on different objects while away from humans and animals. So incubation periods, modes of transmission. Anything further to add to that?
I think the slide that I'm trying to put up back, that slide again, it is believed that on certain conditions that the virus can survive up to 5 days. And I think there was one report from CDC that on a cruise ship that the virus was present after a few weeks, but despite it's detectable, it does not mean the viral load is high enough to be infective. So 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 we need to be aware of that as well.
Just to add to that, yeah. And just to add to that, I think that some of those studies that show that there's evidence of virus particles being there may just represent some DNA of the virus rather than live virus. So I think that that's, but I think that what we should be doing is assuming in any situation that anything that we're touching, especially if we're on public transport or in areas where there are lots of people, that we potentially, if we're touching those areas, then we need to be aware that we could potentially be contaminated. And that's why the hand washing and hand sanitizing message is such an important one.
There was a question that came into the chat function. As the signs of conjunctivitis in COVID-19 cases are difficult to differentiate from other causes, how do you manage conjunctivitis cases in the COVID period?
When we first had when we had the first wave of cases, we tried to defer the appointment of patients with conjunctivitis unless they have very severe symptoms, because we know conjunctivitis is not in most cases are viral, and they may not have a very very bad visual outcome. So because the majority of viral conjunctivitis will recover on their own. So that's why we suggested deferring their appointment for at least 14 days. And of course, if the condition worsens, then they can always return for follow-up. But it's also important that you use the questionnaire to screen out the high-risk cases. For example, those with fever, those who had recently traveled, or those with contact with coronavirus. And in case you have these high-risk cases, you still have to see them, but ideally in a designated area, and also with the appropriate personal protective equipment, such as the N95 respirators and eye protection.
Yes, and thank you for those very practical suggestions that you provided in terms of patient triage during the presentation as well. Another question is there any other different ocular sign than conjunctivitis in children who contracted COVID-19?
I have looked at there is a recent letter which has described in one case that in a small child that presented with lid edema and injection of the eye as the first presenting sign of COVID-19. But I don't think there are other reports. Gerard, are you aware of other reports of ocular manifestation in children?
Yeah, not so much in children. Certainly in Australia, the evidence that we have suggests that children tend not to get infected as much as adults, which is obviously different to some of the other viral infections that you can get. So we are not seeing many children at all. I have seen two publications, one suggesting that children can get a very unusual peripheral digital inflammation, which is thought to be a vasculitis, so that their fingers and toes can almost look as if they've got almost like an infection or at the end of their digits. So that's been one rare presenting symptom in children. And the only other one that I'm aware of has been the rare discussion or the rare detection of a retinal vasculitis. So these have been isolated cases. But as I said, generally speaking, children, even though they can obviously be affected, tend not to be as vulnerable as older members of society.
Thank you for that. Another question, as your presentation, intraviral infection and operations can proceed, What about laser procedures like PRP? What precautions should we use?
That's an excellent question. And for surgery, as I've mentioned, we have suspended most elective surgeries, and but we still continue our emergency surgeries. And for emergency surgeries, we have recently published a risk stratification protocol, which we for all emergency cases, we will screen them using the questionnaire, and also fever. And if they are considered high risk, then we will test all patients using the PCR rapid test on respiratory specimens. And if they are screened, if the test came back negative, then we will operate using standard precautions, that is with surgical mask, without the need of N95 respirators. If the cases are tested positive, and of course
I think we might have just lost Kenneth there. Can everyone else hear me?
I can hear you, Judy.
Okay.
I'll just, while we're waiting for Kenneth to get back on, in Australia, things are a little bit different in that we have been successful in flattening our curve relatively quickly. And whilst we had 1 month of the same very restrictive triaging and emergency only procedures as Hong Kong, as Kenneth really very well articulated, we're now moving into a situation where we are returning to more routine surgery, and so returning to cataract surgery. And the question that I would ask Kenneth, if he can get back on, is whether or not, at what point do we start returning to those circumstances where we're doing routine surgery? When is it reasonable? What are the indicators that it's reasonable? Because I suspect that most of the people on this webinar are still in a situation where their country is trying to get control of the COVID outbreak. But at some point, life has to return to normal, because there are also negative health implications to keeping everyone locked up for a long period of time, not just in terms of their mental health, but also in terms of their eye health. We all know about cataracts that we booked in the clinic that were moderate, and by the time they've got round to having their surgery, they've become much more complex. So there is a time point, and you need to have an exit plan and be thinking about what are the timelines for you coming out of this, because you will all come out of it in the end. So if we can get Kenneth back online.
He's back, Gerard.
Great. Kenneth, I might have that to you. At what point is Hong Kong planning to loosen things up?
We are making plans to resume some of our surgeries and also outpatient clinic. For surgery, we're trying to do it in a stepwise approach, but the main issue is the shortage of personal protective equipment, especially cases that are done under general anesthesia. We are not able to save too much PPE at this moment. So, and even in Hong Kong, with its close proximity to mainland China, we are not getting adequate N95 respirators as we have wished, we have hoped. So that is a crucial factor for. So it's striking a balance between the needs and the challenges. So it is a main problem is the PPE. Gerard, how about the situation in Australia?
I think I was just talking about that whilst you're offline then, Kenneth. So we did suspend all surgery except emergency surgery for a period of a month, and now we're beginning to open that up again. So we are returning to doing routine cataract surgery, for example, and part of that was trying to the rationale behind it was trying to reduce contact with people, but also we did have an initial problem with the PPE, but that's now been resolved in Australia. So we're producing our own, and also we've been fortunate enough to get some from overseas. So I think that in Australia we're just beginning to move to opening society up, and also to broadening the scope of the medicine that we're practicing. We may well see a second wave. It's possible, but we now I think have a pretty good strategy in place. And I guess my point was in raising that question was that everybody who's on this webinar, they're going to at some point have to think about what they're going to do when they get to the other side, and how they're going to change things with their triaging, and it's a very complex situation, and I suspect it'll be different for each country, and you'll be guided by your chief health officers. But it's interesting though that Hong Kong, who has done so well, that you are still in the situation, despite very low levels of active cases, are still in quite a significant lockdown.
Yes, yeah, we are planning our resumption of services, and as you've mentioned, it is likely that we have to maintain certain infection control measures, including access control, logistic management, and the continuation of the disinfection of the environment. So that will have a substantial effect on our efficiency. We are proud for having a very efficient clinical service in the past, but it is likely that we cannot maintain that same level of efficiency and anymore, unless the COVID-19, as we have eradicated the whole COVID-19 globally, which is unlikely to happen very soon. Yeah, so I agree that we have also started to do cataract surgery in Hong Kong since this month. There was a lot of concern about whether the patient should wear a mask during the operation, despite the use of a sterile drape. We had some discussion on that, but so far we have managed. The hospital management has decided that there's no need for patients to wear additional surgical masks under the drape. I guess it's because we have a relatively low prevalence here at the moment, so they are generally a little bit more open to reduce the infection control measures.
Thank you both for that discussion. Are there any further questions from the participants today? Have you made any modifications to the vacoemulsification procedure?
We haven't actually. So we would like to think that our sterilisation and sterility environment within our day surgery is perfect. We actually haven't had any sort of an infection in our day surgery for over a decade now. So we haven't made any specific changes. I'm not sure whether Kenneth had. We're also taking precautions in terms of still triaging patients on the basis of their history and their symptoms, and we are obviously prioritising those patients with who've got severe disability associated with their cataracts. So that's how we're dealing with it now. The other thing that the government has insisted on is that when we return, we returned to only a 25% capacity in order to allow appropriate social distancing both pre-operatively and post-operatively. I don't know whether Kenneth had any different ideas about that.
There has been a lot of discussion whether retractomy and even phaco emulsification are considered aerosol generating. The Royal College of Ophthalmologists in the UK and also the American Society of Retina Specialists have issued recommendation on the use of N95 or FFP3 respirators for retractomy surgery. In Hong Kong, we have not taken up that recommendation, and I heard also this was not taken up in Australia. I've recently heard of Mr. Nick Hayes from Bristol in the UK. He has done some studies on the aerosol generating nature of retractomy using high-speed cameras, and he thinks there is some evidence that retractomy can be an aerosol generating procedure, especially during the at the fluid air interface at the trochus. That's where it occurs, and of course, even if it's aerosol generating, whether the amount of virus is enough to cause infection is not known. But at the moment, we're just doing phaco and retractomy just at the old same way. Gerard, any thoughts?
You know, it's the same for us, really. I noticed that's Jagadesh who has asked the question. So thank you, Jagadesh. But no, we're just performing the cataract surgery in the same way that we always have. I'm not overly concerned about, you know, contamination or contracting any disease that way. I think that it's a reasonable thing to do, and you know, everyone who's practicing cataract surgery is going to have to come and sort of you know, come to terms with that at some point. I'll have a look at that study from Bristol, but I don't think it's really going to change my practice based on what Kenneth has shared.
Gerard, Jagadesh has just added a second part to that question. Any reservations with femtosecond assisted cataract surgery?
Well, the femtosecond cataract surgery does add an extra step to patients moving around a little bit, so I think that that's a potential issue, but it's not really exposing myself, I don't think, to any greater risk. Moving the patient from the femtosecond laser to the main operating theatre, I think, is a bit of an issue. But no, I'm continuing to practice now that I'm back doing cataract surgery the same way that I always have. My personal preference is to use the femtosecond laser in complex cases, and I'll continue to do that.
Thank you, Gerard, and thanks to everyone for sending in those questions. Really helpful with our discussion. Are there any further questions? Otherwise, we will wrap the webinar up, keeping it to an hour as we promised you. Thank you to Dr. Kenneth Li and to Professor Gerard Sutton for the presentation today. We very much appreciate your advice and input and recommendations, and for your time in presenting and in preparing the presentation. So thank you. Thanks to everyone for joining us on the line and for the questions. I'd like to thank our Little Sight for All team, Nita Bize, Cesar Carrillo, Sister Math and Yi Win for their help, not only in putting today's webinar together, but we also have a COVID-19 specific website that's being launched tomorrow, and there's been a lot of work that's gone on to build the site and to develop the content, and the team's done a lot of work around that. We'll share the link with you all tomorrow. so that you'll be able to have a look at that, and the idea is that the content will continue to be updated. And we're also pivoting COVID-19 projects in Myanmar and in Cambodia, so the team's been working on that as well. So we thank you for your participation and your interest, and again thanks to our presenters, and wish everyone health and safety at this time.
Judy, can I just ask one last question? So Kenneth's excellent presentation will be available on that website?
Yes, if Kenneth's happy to share it. We're certainly putting the recording of today's presentation on the website, and with Kenneth's permission, we will add that as well.
I'll be happy to do that.
Thank you.
Thanks, Kenneth. Thanks, Judy. Thanks, everyone.
Thanks all.
Thank you.
Bye-bye.
Bye-bye.